Stewart, thank you so much for meeting with us today. Full disclosure, you are somebody that I do work with, so I do know a little bit about where you were with when we first met to where you are now. But please give our listeners just a little bit of background on your first diagnosis with your heart and kind of what you were told versus your first kind of diagnostic thing that they did to you, and then your first procedure that you got, and then we'll walk forward from there.
All right, try to do a quick history. Back in 2007, I was having problems breathing.
Okay.
And when I was sleeping, I was using a couple of pillows to sit up, and I didn't quite know what it was. So I went in, and the first doctor I went to, did a couple of tests, and one of the tests he did was an echocardiogram, which basically tells you the amount of blood that your heart is pumping. They call it an ejection factor, which is a percentage of what your heart is pumping as far as the blood through your system. And normally a person would have somewhere in the range of 50 would be a decent ejection factor. And as it goes down from there, they put you in different categories on what kind of condition your heart is in, and it's different numbers. I won't get into that, but mine came out at like 35, and when they looked at that and all the blood tests and all the other work, they decided that I had what they call congestive heart failure, CHF. And at that point, because my heart was so weak, the diagnosis back then was, sometimes said 5 to 7 years. And what would happen is your heart would slowly deteriorate, and my heart had been attacked by a virus which had affected the muscle. It killed some of the muscles, so now my heart muscles are weak. And what that does is that pumps less blood to your organs, and the less blood that pumps to your organs, the less they work. And so, like if you're pumping to the brain, you may not think as fast, or if it's pumping to your liver, it may not work as well. And as your blood slows down, you don't get as much, then things start to stop. And the first thing that would happen is obviously at some point your system would shut down without it pumping enough blood, and then you would no longer exist.
So it's not a good prognosis.
It's not a good prognosis. It's a long-term kind of sentence to say at some point your heart's going to, because it's so weak and the muscles aren't there, that your heart can't regenerate those muscles. One of the things about the heart is they can't regenerate those muscles. So you would not be able to regenerate it, and they would certainly degenerate. And when they did that, then at some point you wouldn't be getting enough blood to supply to your organs or your brain to stay alive. And at that point, you'd either have to have a heart transplant, or you would just slowly, your organs would shut down and you would die.
Right. So take me from that diagnosis of congestive heart failure to kind of what you did.
At 75, when I first got the diagnosis, I was a little bit in denial about the fact of what I had. And I think that's probably natural that people would be saying, well, that can't possibly happen to me, knowing that that this could get worse and worse and worse. But on the other hand, you can't breathe, you lay in at night, and you can't run, there's certain things that can't happen. And so you just do what they tell you to do.
Sure.
And at that point, what they tried to do is save my heart by giving me a set of medications which basically try to comfort the heart. It makes it beat a little bit slower. It dilates some of the blood, the veins that allow more blood to get to certain areas. And it tries to keep that ejection factor as high as it can.
Right.
That seemed to work in the fact that the other thing that happens is as your system slows down and you don't get enough blood, you start to develop liquids in your body, like water build up around your heart, and you get what they call edema, which takes away your ability to breathe because you have liquid around your heart. So one of the first things they want to do is to get that out of your system, which they use a diuretic to do that. And once you can breathe again and sleep well at night, then they start working on the other parts to make the heart more relaxed and make it pump more efficiently.
Right.
And there's all kinds of drugs to do that, and they do it from different places. Whether you can make it pump faster, pump slower, pump more steady, dilate your vessels and things like that. So that was the first course. And as they looked at it, they indicated to me that I started to get what they call atrial fibrillation.
Okay.
So AFib comes with the wounded heart. The heart was just getting all these extra beats, and I was going into atrial fibrillation. Stop me if you got a question.
No, like it just complicates things.
It just complicates things. Now I've got atrial fibrillation, which means the top part of my heart is beating very fast. It's not really pushing as hard as it should be to get the blood to my body. So on top of having a weak and sick heart, with the muscles being deteriorated because of the virus, now I have this other thing, which is now also making the heart a lot slower.
And the AFib is not going away.
Yeah, it would go away.
So it's persistent.
Yeah, you could have shocks. No, you could have it, and you could get it shocked away, and then stay away for 6 months, a year. But the longer it stays there, the more frequently it comes back, and in the end, you probably end up with full-blown AFib. Now, some people are symptomatic, some people aren't. I happen to be symptomatic, which means when I had AFib, I felt like I had the flu.
Okay.
It really makes you tired and sick, and so your heart's beating like that. So now I've got atrial fibrillation and I've got the congestive heart failure. So for atrial fibrillation, they now have other drugs that they want to give you. There's two things you can do: take medication or get an ablation.
Yeah.
So I did both. I started on the medications first, which helped keep me in sinus rhythm. The alternative to AFib is sinus rhythm, which most people are in. So those medications put me back into sinus rhythm, but occasionally I would go into atrial fibrillation, and at that point, I would have to be shocked out of it.
Right. So cardioversion
to get me back into sinus rhythm. And that went back and forth and back and forth. And
so it would work, but it wouldn't hold. Is that what you're saying? Okay.
And the longer you went, the less it would hold.
Okay.
So I had what they call an ablation, where they go in and they try to find the spots where these extra electrical beats are coming from that makes your heart fibrillate,
right,
or flutter. Sometimes they call it a flutter. And they try to eliminate those by burning those, and if they can get rid of those, then the conductivity goes back to the sinus node, and your heart goes back to normal rhythm, and you're not symptomatic,
right,
and you can move ahead. And so that's basically what I was doing. Now after the first ablation, I did decide that I wanted to try some stem cells.
Okay.
So I did do a stem cell procedure, which seemed at some point to work. Now, I'm not sure how long it worked, but everything got better. The ejection factor went back up. I didn't have the edema, although I was taking the diuretics.
Right.
So I felt good. Quality of life got improved, and I did that. And then
what is your time frame on that now?
Well, it's 2007, probably 2008, 2009. I probably had my first ablation and my first.
So you've lived with this for a couple of years already.
Yeah.
Okay.
Now, what also happened was, I'm sure I got my time right on this, is that they also told me when the AFib came in and with the congestive heart failure that I now had a chance that I would get some ventricular tachycardia.
Okay,
Which is
SVT or?
Yeah, which is the bottom part of your heart. So where your AFib is your atrium, VT is your ventricles.
Right.
And that's very dangerous, because if your ventricle goes into tachycardia, starts beating real fast, these extra beats, then your heart actually stops. And when your heart stops, the blood to your brain stops, and your whole body stops, and you basically die.
Right.
And so what happens is they have to defibrillate you with a defibrillator. And or they can put a defibrillator in you and plant the defibrillator, which will, if you die, it will go off without somebody bringing one up, and it'll start your heart beating again. So I was in an airplane flying into Atlanta about 2 years or 2 years after I'd being diagnosed, and I went into ventral tachycardia, and I had sudden death syndrome, and I died on the airplane. But there was a steward on the plane who got the defibrillator out. They defibrillated me, got me to a hospital. I was in Atlanta. I stayed there for for a while, and then I ended up getting a pacemaker put in there.
Okay. A pacemaker.
Well, I got a defibrillator put in
Yeah,
there, which
right.
means if I went into ventricular tachycardia, it was a pacemaker, which they weren't using that. They were using the defibrillator. So what happens is, if your heart stops, the computer in the defibrillator, it's a small thing about the size of a cell phone, tells the machine your heart stopped. It shocks you back to
Right.
life, just like it would if you had a
Right.
defibrillator, an external defibrillator.
It's using a smaller voltage because it's in your heart versus what they
What
did
would
on
be-
the with
yeah,
the
with
paddles.
the paddles.
Yeah.
So that happened, and I had the defibrillator put in, and then that added another complication, because with that, I had a 1-lead defibrillator, and it was implanted in the top part of my heart, and it couldn't read. I don't want to get too complicated. It couldn't read exactly what was going on. So if it wasn't ventricular tachycardia, it was just a really bad case of AFib, it might think I was in ventricular tachycardia, and it would shock me.
Give you therapy.
Therapy.
Yeah.
And the therapy is a pretty big shock. It's like a kick in the chest or a big punch in the chest. And at that point, you don't know why it's going off. You think heart might have stopped, or it was the AFib or whatever.
So it's scaring you.
It's scaring you pretty bad. Especially it scares a lot of people around you. The hardest part is that if you're standing somewhere and the thing goes off, it's you know it went off, and everybody else knows it went off. But in any case, so that was the next step, was to have the defibrillator implanted. And again, that I had a couple of occasions where I did have ventricular tachycardia, and it did go off. And then I had some cases where it was atrial fib and it did go off. So you never really know. Now the thing is that you've got this defibrillator which is implanted in your chest, and what it does is it also can be read from the outside. So you can remotely read, and it's like a little computer. It keeps the records. Except with 1 lead, it doesn't make the records very well. It
Okay.
doesn't keep the records very well. So fast forward a few years, going through these things and trying to keep my congestive heart failure straight, trying to keep my AFib in control, and then also now trying to keep the ventricular tachycardia in control.
Would you say that your life had kind of leveled out, or was it declining as far as how you felt during this period of time? Were you feeling better?
Well, no, not really, because when you first get diagnosed, you feel really bad.
Okay.
And you feel sorry, and you're for yourself, and you think, well, this is, okay, it is what it is. And then when you have the heart attack, we have the cardiac arrest, whatever we call it, and have to be defibrillated, and then when you have to have an implant put in your chest,
Sure.
all that together is not very, it's not very much fun.
Yeah.
And you start getting shocks, knowing that any time you could keel
Yeah.
over.
Oh, I
and
can't
hopefully-
imagine. So your
hopefully
quality of
it
life wasn't improving at
very
this
good
point.
all.
Okay.
And the exercise wasn't that good, but I kept trying to do that I had to do something, and the exercise and changing your diet, taking
Sure.
the right medications, and do what you're supposed to do, and having the ablations, seemed to hold everything in place, and then it did seem to get a little bit better.
Okay.
And once you wrap your head around all the things that are going on, you can start to work with that and
Were you doing a support group or anything like that during this time?
yeah, I had a couple of support groups I dealt with.
Was that beneficial?
It was, except there weren't very many, and there aren't very many. And I've just found a couple that are
Would that have been helpful to you? Do you
Yeah,
think,
very
if-
much so. I think just being able to talk, because a lot of times the developer of these devices, whether it be Medtronic or Boston Scientific or St. Jude or whoever it is, they don't really want to tell you a lot. They like you to talk to the doctor. Doctor holds it close to his chest, doesn't really know kind of what to say, what not to say. So you're really kind of out there with a lot of, not so much misinformation, but information that you just think up in your head because you don't have anybody to answer the question on what about this. And even if you did have the right person, he might not have the answer.
So you got a ton of technology, but you don't really have the tools to use any of it.
Right,
I mean,
or to
you-
understand it.
You're given a computer, but no instruction manual.
Right, and somebody else is running it for you.
Sure.
And you're not sure who they are,
Right.
or where they are, because you don't ever
And
see
they're not
them.
with you every day
No,
to determine, how you're
Right.
feeling.
And what's going on.
Right.
So So we go along like that for a while, and things seem to get better, and then things get worse, and things get better, and things get worse, and a couple more ablation procedures worked for a while, didn't work. And so finally, at the end of the day, I was in AFib, and I was still having the ventral tachycardia. I was still getting shocked, and they thought that the only solution was to have a multi-lead defibrillator pacemaker. Combination put in, and that was 3 leads.
Okay.
So now
and
I have
that's
a lead.
state of the art.
That's state of the art, top of the line. They called it CRT. The CRT was put in, which had a atrial lead and 2 ventricle leads.
Okay.
So at this point, if something went off, number one, it could immediately, by looking at all those leads and the information it was gathering into the computer that was in the device, it could tell you pretty much what it was. So you'd know whether it was atrial fib or whether it was ventricular tachycardia and what really caused it. And so from there, you had a little bit better feeling. Plus, this device has pacing mechanisms in it, so that if your heart starts to do something funky and you start to go into ventricular tachycardia, it will try to repace you, send different electrical
In real time.
in real time, and change it and stop it from happening.
Okay.
And if it does happen, it'll try its best to keep it from happening.
Right.
But if it does happen, it goes off immediately, and then then you can go and have a reading done, and you can tell exactly what the cause of the problem was, which in your own mind makes you feel a lot better.
Sure.
I mean, it doesn't make you feel great, but at least you know whether it was atrial tachycardia,
You don't have to
atrial
guess.
fib. You don't have to guess anymore, and then you can approach that problem with what the device settings are and things like that.
And when was the CRT?
That's been about
placed?
2 years.
Okay, so now you've given us a good kind of background on where you were to where the CRT was implanted. Now,
Yeah.
from the time the CRT was implanted to today, what has your quality of life been, would you say? Has it improved?
Well, one thing happened. After I got the CRT, things got better because I could understand things better, and it was pacing me a little bit better. But I was still having a pretty bad atrial fibrillation problem, and the ablations didn't seem to be working, and the cardioversions didn't seem to be working. So at that point, the AFib was affecting the ability of my AV node to transmit, I don't want to get too complicated, your top heart beats first, sinus rhythm sets it off, go through an AV node, the bottom heart pumps, top, bottom,
Right,
top,
right.
bottom, top, bottom, pumps the blood out. Well, because the top was so much in AFib, that the bottom was getting confused, and that the pacemaker was not being able to think about, it was seeing all this other stuff, and it was
Noise.
getting a lot of noise and other things going on. It might go off, or it might try to pace when it shouldn't be pacing, or it might not pace when it should be pacing, right. So at that point, they ablated my AV node.
Okay.
Now, this is kind of what they used to call the last.
Yeah. Now you're really dependent on technology.
That's the last place you go.
Yeah.
When you got what I had, when you have the combination of things that I have. So at that point, the AV node had been ablated, so now I'm totally dependent on the battery and the pacemaker making the heartbeat.
Right.
And it's set, and I have no more control over my heart. Maybe at some point there's a little bit because of certain things, adrenaline, maybe a little caffeine and stuff, but generally the electrical system on my heart is totally dependent on this machine.
Right.
And so the key now is to not let the battery go run out, but the key thing is to just get the machine set so it's giving me the best possible pacing.
Right.
And the best possible reading, and if I have some kind of event, whether it be a shocking event or just it could pace me out of it. So it's a full service machine now.
Right,
It's
right.
not only making my heart, keeping me alive by making my heart beat, it's also monitoring and keeping my heart from beats getting out of control. And if it does get out of control, it tries to bring it back in control before it shocks me. If ventricular tachycardia stops my heart from beating.
So this is one of the main points I wanted to touch upon, was that technology, and you're the beneficiary of the technology, has come to the point that someone with your situation can actually get something put in their body that's taking the place of what your body is supposed to do,
Yeah.
but is also allowing you to live a fairly high quality of life. Okay, you're able to exercise. The The pacemaker is able to adjust the beats that you're getting to accommodate the additional exercise that you're doing to, you're taxing your body. Your body needs more blood circulating. Your body needs more oxygen circulating. So this device is helping provide that. And if we were to back up 50 years, someone with your situation, probably that obviously wasn't available to them, but their quality of life would be doing more of this. It'd be
I would have died of congestive heart 50 years ago. I'd be congestive heart.
We wouldn't have this conversation.
I would have never gotten to the AFib.
Right.
Probably would have never gotten to AFib.
One of the things I wanted people to take away from this was that technology's improved, and the improvement in technology is allowing people to live a higher quality of life. You're a testament to that. We think there probably should be more information available to the people who actually have the hardware in their body, support groups, or at least talk to people who are familiar with this that can tell us, to take advantage of some of these settings that are in there, but just give people an understanding from your perspective of what it has been like on this journey to where you are now, and how you feel like you've done, so to speak, with this.
Well, I think the key is quality of life.
Yeah.
And I think as you look back or you look especially if you look forward, what's the quality of life going to be, and how am I going to feel, and what am I going to be able to do and not do, and how is that going to affect the people around me?
Sure.
And what's going to happen. And now I'm 71, so that's getting up there. And at some point you pass the point of heart transplants because you're just getting too old,
right?
And your options start to dwindle on what is available, and the only thing that you can rely on is what is not known yet or what is going to be developed. Yeah. And with the speed of the way they're developing things, especially the things that are left are improve the technology of the pacemaker or the defibrillator to allow you to get different functions and live better, run farther, go faster, whatever, sleep better. And then there's the medications, and you're not getting too much improvement on the medications, but the blood thinners have improved dramatically, so you don't have to take all these tests all the time, so that's good. A lot of them are very dangerous, they have bad side effects, and so they're making the ablation process better. Now not only are they ablating the atrial fibrillation, they're now being able to ablate PVCs, which can also cause a lot of problems with your heart rhythm and your quality of life. And they're now being able to look at the VT itself, because the VT is the same thing as a atrial fib, it's just in the ventricle.
Right.
So you've got a short circuit somewhere that needs to be ablated. That circuit needs to be destroyed so the natural system can work. And so that's growing too. In my case, what I look at now is the advance in, the other one is stem cells.
Absolutely.
I've done it in the past. I felt like it worked, and I just was way early in the process. I think now it's gotten so much more, more government approved. More people are doing it. It's more in the mainstream, and I think it's something that everybody should look at. I think the other thing is the improvement of the technology of the device that you're wearing, and as somebody who's got the device, what you want is information. And as more people get it, and especially the newer devices that are much more sophisticated, that can do a lot more, those people, like myself, want to know how it works. Yeah. They want to know who's is driving a car and setting your automatic whatever,
right.
Your speed, or if it's a self-driving car, all this stuff is looking around and making the car drive right, stay in the right lane. Well, you want your heart to be the same way, and that technology, as it gets more improved, that's great. But if there's somebody somebody's writing these programs that do that, but you want that person also to be able to explain to you what your options are, or at least sit down with an electrocardiophysiologist and have him go through
right.
the options and say, look, if you're going to try to run, let's check this thing, let's see what your heart rate's doing. Do we set this parameter this way or that way? Because the device I have now has what they call an accelerator. and it's basically physical. I mean, when my foot hits the ground more than so many times a second, it makes my heart rate go up.
Because it feels it
I'm
somehow.
totally dependent on what that machine reads from my body to make my heart rate do. So if you're going to go out for a long walk, you want your heart rate up to a certain level, and you need to be able to get it there.
Yeah.
And all these variables are what makes it do that. So you need more information, and you need people that you feel like are telling you what's going on. And it'd be nice to get more feedback from your device. It goes to your doctor or your hospital. You never really get it. They filter it out,
Right.
and then it comes to you in some little, well, you're fine. What the fuck, excuse me, what does that mean?
Right.
When I'm fine, you don't know who I am.
You would love to have
More access to my
feedback
information.
in real time that you can interpret,
Right.
versus going all the way to your physician, then they have to take a time to look at it, or whoever reads these things, and then they give you the synopsis.
I mean, every 6 months you go in, the guy looks at it and says, you're fine? No,
Yeah.
you need to know more, especially if you're having any problems, or you perceive you're having a problem, and there's nobody there to go to.
Right.
Now, there are more, like I say, the more people that have these devices, the more they're getting active.
Right.
And the more the medical community and the device community is having to put out information on these. And they do now have support groups in most of the major heart places that you can go and sit down with another group of people that have kind of the same situation
Right.
you've got. And you can talk about that, and you can kind of get a lot of that out. It's kind of like group therapy
Right.
almost, but it also is a good place to get information and contacts on what you do. So if you're in that situation where you can't get the information that you want, you need to go back to the institute or the device manufacturer and say, where do I go to get this help?
And they need to be more forthcoming.
Absolutely. And they're just not. And I don't know whether they're scared somebody's going to sue them if they say the wrong thing or whatever it is. You're just not getting the information that you want or the feedback that you need. And there's so many new devices out now. There's another device now that reads the pressures. It's called a MIMS device. It goes into one of the veins in your neck, and it tells you what the pressures in your heart are, kind of like your blood pressure, and you know whether you've got
Just
too
another
much
sensor.
water. Just another sensor, and that information goes somewhere. Now they have sensors that'll do your blood pressure. They have sensors that'll do everything. Well, that information has to go somewhere. It has to be put together. Somebody has to read it, and then they have to decide what to do to change things. So I think that's what's happening going forward, and more people need to be involved to say, we want the information, and we need to have access to this stuff.
Well, it's people like you that help get that, out there,
Yeah.
and it's people like you who give people who are maybe in that situation that you were in 10 years ago, that's beginning their journey, that look to you and find inspiration and hope that no matter what they're experiencing, that there is a possibility that their life can improve, and that for those people the technology will be even better for them when they need it.
Absolutely.
Going forward. So, Stewart, thank you so much for your
Sure.
time today, and we appreciate you sharing your story.
All right.
Thank you.
Thanks.